So, good morning. We're going to be talking today about CT angiogram. It comes out of the Prevention Myths book. Let me get us all set up. Can you see that okay, Gilbert?
It's Aspen, Doc. Yes, Doc.
Okay, sorry, Aspen. So, plaque is one of the most important things, cardiovascular plaque. And it's at the end of at the end, it's not the root cause, but it is the next to the last cause before you have a heart attack or stroke for the vast majority of heart attacks and stroke. So as well equipped, as efficient, well, not efficient, but as powerful as medical care is today, you would think that we would know how to measure plaque. And most people do think that we know how to measure plaque. In fact, most doctors think we know how to measure plaque, but unfortunately we don't. And guess what? That's one of the reasons why we have so much confusion in preventing heart attack and stroke. That's one of the reasons why we still don't predict them well at all. So there are a lot of docs that understand that we don't predict these things very well and we don't measure plaque very well. So there's still a lot of work going on. What's the standard? We know that the standard in most medical practices is the patient comes in and says, "Hey, doc," sort of like Tim Russert did with his doc. "Hey, doc, I'm having some problems with my blood pressure. We're having some issues. Can we just do a stress test?" Well, stress tests are really bad for predicting heart attack and stroke. And they sort of measure, they give us a bad estimate of cardiovascular plaque. In fact, unless you have 50% or more of the artery in the heart occluded, blocked off with plaque, a stress test is going to look like you're just fine, even when you're not. And guess what? That's exactly what happened to Tim Russert and all these other people who've had heart attacks after having a normal stress test. So you look at other things. We've talked about calcium scores. Calcium scores have a lot of advantage, but they also have some disadvantage. One of the advantages is they're available in every large town and multiple places in the country. They're available in the vast majority of small towns too. They're just very available. Another advantage of calcium score is that it's not that expensive and it's well standardized. But what's the downside? The downside is calcium is not the same thing as soft plaque. Soft plaque causes the risk. Calcified plaque is stable. It doesn't create risk. So, in fact, that's one of the things we'll look for with the third way of measuring plaque, and that is looking at a CIMT. It's an ultrasound technology. The advantage to CIMT is that it will show you soft plaque. And you begin to understand, okay, how much degree of calcification, stabilization do we have of that plaque? So that's the major advantage for CIMT. But as with all of them so far, each one of these has a disadvantage. What are the disadvantages for CIMT? Number one, you don't see them very often. There's a major standardization issue. It takes incredible skill and focus from the manager, the owner of whatever imaging company you have, to make sure that we're actually finding the right plaque that we can gauge it. I go into a lot of details on that in the book, the Prevention's Myth book. I also go into details on that on several videos, but we haven't really talked that much about CT angiogram. It is the up and comer. It's a new way of doing it. And it's using CT technology like the calcium score, and it gives you a great picture. But there are still some problems there too. We're going to talk about those today. Before we do, just a quick introduction to the channel, what we do, what kind of information, content's available for you. We focus on cardiovascular disease, meaning heart attack, stroke. But once you start talking about how to prevent that, there's a whole bunch of root causes, and like plaque, what we would call, maybe the lawyers would call proximal causes. One of those real deep root causes that we haven't, as a society or as a medical group, a medical profession, a key cause is the secret of sleep. Sleep. If you miss your deep sleep or REM sleep one night, you can get increased insulin resistance for the next 48 hours. So it's a big deal. But what are we doing about sleep? Not a whole lot. What can we do about sleep? A lot. And it starts with recognizing the importance of sleep. I talked with a patient yesterday. He had a lot of good stuff going on, but he said, yeah, my wife tells me I snore. And I've always felt like, well, most of us snore. So what? So what? It's a big, big deal. So if you have an interest in that, we have a sleep doctor that's worked with us a good bit, a fellow named Param. He's come on and joined us and talked about sleep a couple of times. We have talked about coronary angiography. Again, a chapter that we cover in the Prevention Myths book. Coronary angiography is another very common, very, quote, standard way of measuring plaque. But be very careful if your doc says, let's go do a coronary angiography. What is that? That's also called a cath. You go to the cardiac cath lab, they inject dye, but they inject the dye by first going into your groin, usually, sometimes your arm, but your groin with a needle, threading that needle up to your heart, or threading a catheter from the needle up to your heart. I'm not going to get too technical in terms of that, but we've talked about it before. It's expensive, as you might guess. It's painful, as you might guess. And once you start going down that path, it's really hard to back up and say, what do the results actually tell me? And what's the best response? Usually, if you're a hammer, everything looks like a nail. And if you're an invasive cardiologist and you recommend a cath and the patient has plaque, quite often you're going to say, well, we need to stent that. And the evidence is pretty clear. That's not going to prevent a heart attack. No matter what your doc tells you, it's not going to prevent a heart attack. So again, this is the kind of content that you can find on our channel. Our goal is to help people understand how to prevent the major killers and disablers. Now, there's some core curriculum, some core content. You can spend just 3 or 4 hours and know a lot more than 95% of the doctors in the US and other places about the real causes of heart attack and stroke. The biggest unrecognized cause is unrecognized prediabetes. We've got courses, we've got other things on how to recognize that, how to manage plaque, how to measure plaque, some things like that. So one of the ways we do that is a webinar program. You can actually join other people and go through this experience in a very, very cost-effective way of doing it. Another way is courses. I mean, talk about cost-effective. Quite often we'll give away some of these for free. So even if you pay for it, it's usually $29 to $39. Again, you spend an hour or two and you know a lot more about plaque, insulin resistance or prediabetes, heart attack and stroke prevention, cardiovascular inflammation, key items that your docs it's been proven. Docs don't understand these processes, these issues very well. So unfortunately, most people depend on their doc and they're not getting the state of the art. the best evidence, the best information, and a lot of mistakes are made because of that. So if you want to become a patient, we're closing most of our options. They're about filled up. There's a few left. One of the more cost-effective ways of doing that is with a membership. That helps a lot of people in terms of, the bottom line is I've got a lot of stuff on my plate and I'm fairly expensive to see. But again, that's the membership is a great way to do that if you still want to get in. When I said I'm very busy, this is the thing that's making me the most busy right now. It's the Alabama project. We have one now, 4 or 5 doctors in clinics who are focusing on prevention for Medicare eligible adults. And it's a great way for folks that can't afford to see guys like me individually and pay out of pocket. This is a great way to see guys like me who have a focus on prevention in a cost-effective, reimbursed kind of environment. So again, we've got a lot of stuff going on there. It's being very well received. We're helping a lot of people, and we're very excited about the project. And the project's taking a lot of my time. So that's one of the reasons we're having to slow down on the channel options, the channel availability. What a stress test can't tell you. The content for today on CT angiogram came out of a chapter on this book. I wrote this book with a fellow named Todd Eldridge, who's one of the best in the country for getting CIMT out there and available to folks, high quality CIMT. This is, I continue to get more and more people mentioning to me on the videos, on the YouTube lives, patients, other docs saying, I got your book. You don't give it enough credit. It's really good. See, the thing is, I've always felt like it's a little bit dry and dull. It's not like some of the stuff you'd get from your typical internet doc. It doesn't have a whole lot of clickbait on it, but it's just the real information, the kind of information, again, that you're not going to get from your doc. So today, we're going to talk about CT angiogram. Lots of potential, but it needs to be standardized. I have to just make a quick comment. Thanks, Aspen. As Aspen and I discussed, I had a viewer and friend call me recently, and he and I were talking about doing some potential work together in the future. He's writing a great book. His name is Daniel Trevor. I've helped him a little bit with that book. He's been very gracious about giving me credit for that. Hopefully the book will be coming out over the next few months. He made a comment this weekend when we were talking. He said, "Hey, Doc, you keep saying, and here's the water ball, but it's not a water ball." And so I went back. I had gotten confused. I needed to talk with my production team, Aspen and Gilbert. So again, thanks, Aspen, for clearing up my confusion on it. So CT angiogram, what does it stand for? Computerized tomography, angiography, or angiogram. It's a measurement of plaque in the anatomy of the coronary arteries using intravenous X-ray dye and CT imaging. So, anytime you use CT, you're going to have radiation. The calcium score is a CT technology. The radiation is minimal with calcium score. We'll talk about that some other time when we're talking about calcium score. It's not quite so minimal with CT angiogram. However, it's significantly less than what you see with something like a cardiac cath. Now, there's a lot of data supporting the diagnostic accuracy and prognostic value of non-invasive coronary angiography by CT. It's challenging the role of stress testing. So here's one of the key point that I want to make. If your doctor's saying, let's get a stress test, and you haven't had a CIMT, I understand good CIMTs can be hard to find. If you haven't had a calcium score, if you haven't had a CT angiogram, stop, think, consider these things before you go straight to a stress test. That's one of the most important points of this discussion today. You see, CT angiogram is typically performed in a radiology department or an outpatient imaging center. It's a minimally invasive test. You do have an injection, you do have dye, but instead of going up with a needle and then catheter through your groin to your heart, you inject the dye out in the arm. So then you inject that iodine-containing contrast material in the arm. A few seconds later, they start doing the CT scanning. They examine the arteries, and they get images like this. As you can see, these are very, very powerful images in terms of what the patient knows and understands. And at the end of the day, if lifestyle is more important than stents, bypass grafts, medications, or supplements, it's important to give the patient an understanding of what they've got in their heart. In fact, I've had a couple of patients and volunteers say to me, you know what, doc, I did get one of those CT angiograms. And here's what I did. I took a copy of that image and I put it on my refrigerator door. One of the hardest things in terms of lifestyle is controlling our diet. And if you have to go through a picture that shows your plaque, your own individual plaque, in order to get to that food, it helps motivate you to think about, do I really need this? Is this the best for my health? Images are reformatted after they do the CT. They put it in a 3D image, as you see. Pardon if you heard the noise, that's outside. Pardon that noise. The big difference between a coronary CT and other CTs is the speed of the CT scanner and the use of a heart monitor. So they have to, this is like the coronary calcium score, the heart's beating. So what many people don't realize until you start thinking about it is the CT, if it's going to give us images like this, it has to get very quick images, and it has to be able to time them. You have to be able to analyze it and time those images to adjust for the movement that you have with the heart beating. Now let's talk about the PROMISE trial. It was the first big study showing the potential of CT angiogram to bolster the current stress test problems. In this test, the ability of CT angiogram to predict heart attack or unstable angina was significantly better than functional tests. Those of you that are listening closely might say, well, what's a functional test? Usually, a functional test is going to be a stress test. So here's the image of the article. Coronary CT angiography is a diagnostic and prognostic tool, a perspective from a multi-center randomized controlled trial, PROMISE. Here was the big conclusion. I'll cut to the chase here. The big conclusion was that coronary CTA, by identifying patients at risk because of non-obstructive coronary artery disease, provides better prognostic information than functional testing, in other words, stress testing. Contemporary patients who have stable chest pain with a low burden of obstructive disease, myocardial ischemia, and events. So again, it's got a good, it gives us more information. We're going to learn a lot more if we get one of these. And with the PROMISE trial, we'll probably, I think, talk about the Scott Hart trial a little bit as well. With most of these, what they do is they say, okay, doc, do whatever you usually do, and that's usually going to be a stress test, but randomized, that's the control group. The experimental group will be do whatever you usually do. It's usually a stress test, and add a CT angiogram. So when you compare what they usually do to what they usually do plus a CT angiogram, that's where you're getting the information that it's better. It's more prognostic. And at the end of the day, you actually get an improvement in health. That's the Scott Hart trial that I mentioned a minute ago. In this trial, one group received the standard evaluation. The other one received standard evaluation plus the CT angiogram. As you can see here, this was a big deal that appeared in the New England Journal a few years ago. And again, unfortunately, CT angiogram, despite appearing in a big journal like the New England Journal, despite the information being very clear that it helps, it's like calcium score and CIMT. It's not as big, it's not as intuitive, and it's not what people have been doing on a standard basis. So very few CT angiograms are being done, but despite the fact that it helps. The CT angiogram group was found to have an increased number and severity of lesions in the beginning. Lesions meaning they just had more plaque. They had plaque more often. They had worse plaque. Now, how could that be? Was that just a random issue, or was it actually picking it up more? It was the latter. The people with the CT angiogram found a lot more plaque. Let's go back and think about it just a second. When you realize that you have to have 50% blockage or occlusion or more in order to show up and have a positive stress test, well, if you add a CT angiogram to a stress test, it just makes sense. Sure, you're going to pick up a lot more plaque. A lot of those people that had plaque, but it wasn't 50%, so they had a normal stress test. So this group actually received more treatment, both invasive and non-invasive, with longer lifespan. They lived longer. Now, does that imply that the treatment fixed it? At the end of the day, that was initial treatment. Once you went into the full 5 years, they really didn't get more treatment than the control group. Yet, they had fewer events and they lived longer. How would that happen? Again, we all know the answer if you just think through it. So you do the Scott Hart trial. You have two groups. In one group, you just do the stress test. In the other group, you do a stress test and CT angiogram. In the CT angiogram group, you find more plaque more often, which makes sense because stress test is going to miss two-thirds of it, actually. So it makes sense that you'd find more plaque in the CT angiogram group. Now, here's the next question. So if over a 5-year period, you had the same number of treatments, but the CT angiogram group lived longer, had fewer events, what's going on there? Well, let's go back and remember something that all of us should know. I said it already. Lifestyle is more important than a bypass graft, a stent, supplements, treatment, etc. And you go back to that example of my patients saying, you know what, I got an image of that thing and I put it on my refrigerator. That's what's going on. People are realizing I've got significant plaque and it's making an impact in their behavior. So the bottom line was the CT angiogram group was more likely to make life-saving changes in their habits. Now, I'm going to talk about a case. We talk about that case in the book. It's an interesting case. It compares, it shows some of the value of a CT angiogram. So Arnold comes in. He says, "Doc, I can't believe you're saying the same thing as the other doctors." Now, whoa, wait a minute. Let's go back and see what that's about. It was because I had told him, "Yeah, I think you need to use statins." So he had come to me because here's what happened. He was 63 years old. He fainted while he was fishing with his son. They took him to the emergency department. The doc in the ER said, "I can't find anything wrong, but why don't you take these statins?" Well, Arnold just doesn't like statins, didn't want to take statins, didn't like the idea of it. So he went to his internist. He didn't start with the statins based on the ER doc's viewpoint. He went to the internist. The internist said the same thing. He did a stress test. Arnold passed the stress test without any problems. The stress test was negative. But then he said, "Arnold, I think, I still think you need to take statins." Well, again, Arnold didn't like that. He knew a little bit about my channel. He knew I had a different perspective on those. In fact, I don't recommend those unless you already have plaque. And then when you do have plaque, we do recommend it. It's very low dose as opposed to high dose. So Arnold came to see me and we did a CIMT. The CIMT was actually normal. It didn't show anything. So that raised some questions. So, what was going on in terms of the fainting? He did have some evidence of cardiovascular inflammation. He had an elevated C-reactive protein. And by the way, Arnold's not his real name. The real name has been, the name's been changed to protect the innocent. Arnold had some cardiovascular inflammation. He had a borderline oral glucose tolerance test and insulin response. So what we knew was that he had some of the underlying causes. He had some evidence that those causes may be active. He had a borderline A1C. And again, when you start looking at this, especially in the baby boomer age group, my age folks, 60 to 65, and younger and older, one of the most common causes of this problem is borderline or moderate prediabetes or even full-blown diabetes. But again, glucose metabolism problems that just have not been recognized. They were missed. And we talk about that in other parts on the channel, plenty of other videos. His basal insulin was 7, a little bit high. The basal insulin that we would like to see is 5 or less. For those of you who are worried about LDL, he wasn't an FH patient. His LDL was 98 and he wasn't on statins at all. So that wasn't an issue. I ordered a CT angiogram. Yes, he had plaque in the left anterior descending artery. That's called the Widowmaker. And the report made it clear it wasn't occlusive. So that's why it didn't block flow of the blood. So that's why his stress test was negative. We did some more work. We were able to go back and make some adjustments on the CIMT and then did find that, yes, there was evidence of soft plaque. I described that soft plaque. I talked with him about the fact that soft plaque can cause a heart attack even if it doesn't block blood flow. The fact that plaque was present indicated that Arnold had been through cycles of insulin resistance and inflammation, as I had suspected. And as I see time and time again, all day, every day, when I see patients. So here's the rest of Arnold's story. 4 years later, CIMT did show continued evidence of healthy arteries if you just looked at it without knowing Arnold's story. His coronary calcium score began to show positive. He agreed to take the statin. He made some changes in terms of his lifestyle. He lost some weight and he started to calcify that plaque that he had had. He knew this was a good result. And it meant that that small amount of soft plaque that he'd had been soft. It had been difficult to find. The CT angiogram helped us find it. And it had risk of rupture. Once he reversed this situation, got it calcified, he knew that he had decreased the risk for heart attack and stroke. He's an anxious guy. He's still a little bit anxious, but not nearly like he was before. He's comfortable that we've found the issue, we've understood it, we've dealt with it, and we know what to do. He increased his exercise regimen. He's doing it daily now. He's feeling confident that the fainting spells were not related to some kind of future cardiovascular event. And guess what? He hasn't had any other fainting spells since then. So thanks for your interest. We will go into Q&A next. So we don't have quite as many people today, and I'm not surprised. That's because most folks don't really get the significance of CT angiogram. They haven't even heard of it. But we've got plenty of people who are interested, and we've got plenty of questions. So let's start dealing with those. The first comment was from me. By the way, we're going to talk about aspirin. We should get a lot more uptake on that one next week. There's a lot of debate about, wait a minute, should you use aspirin or not? It was a standard recommendation for many years. With the Esprit trial last year and a new trial that we just, meta-analysis that we're going to report on next week, it becomes really clear that the standard recommendations have changed. For example, the U.S. Preventive Services Task Force has recently said, we used to recommend aspirin at age 55 or 60. They went back and forth on that. But now we don't, unless you have heart attack or unless you have plaque. So people have heard something different from me from day one. It's a little bit more like I didn't recommend it based on age, just like I don't recommend statins based on LDL level. I recommended it based on plaque. So we'll get a little bit deeper into that. It becomes a very interesting discussion. And again, that's for next week. E.T. himself, aspirin has been kind to me forever. Well, aspirin's not kind to everybody. Aspirin itself has caused significant GI bleeds. It's even caused some hemorrhagic bleeds in the brain. And when I say GI bleeds, I mean, bleeding in the colon, bleeding in the stomach, things like that. So especially as we get older. So we need to know a little bit more about the details on aspirin, and that's what we'll be covering. Bart Robinson, I think from New Jersey. Good morning, Doc. Tuned in as usual and prepping and fasting for colonoscopy tomorrow. Ugh. Great fun. We don't talk enough about colonoscopy. I tell you what, I'll share this personal experience. On my first screening colonoscopy, about, what was it, 10 years ago now? A friend did it, a gastroenterologist in my Sunday school class. And he said, you know what? You're curious, you're a doc, you're into prevention. So I bet you'd like to be awake during this process and see it, right? And I said, I'd never thought of that. And I said, well, yeah, why don't we try that? But it turns out I'm a lightweight. One glass of wine can make me silly. And when they injected me with something to prep me for that colonoscopy, I went out like a light. But then I woke up and the procedure was going on. And Nathan looked up at me and he said, hey, you just woke up. Here, let me show you what's going on. And he pointed over to the screen. Well, if you remember that scene in the original movie Alien, it was when they first discovered this alien. The alien had, latched onto the guy's face. The guy had gone comatose for a few days. They had him in the medical area. And then they were looking at him. He was laying flat across the exam table. And all of a sudden, he wakes up and he starts screaming. And you look down at his belly, and there's something moving around inside his. Pardon me for if you're not interested in this story, or if you don't want to hear this story, but there was things moving around. If you haven't seen that scene, maybe you want to look it up on YouTube. And then this head pops up through the skin of his abdomen, his belly. That's what that felt like. And I got this image in my mind that, gosh, I've got an alien in my stomach and it's killing me. So I said, please put me back to sleep. This hurts. So that is my personal colonoscopy story. Here's the clinical piece. What is it? 50,000 people die every year because they didn't get colonoscopy screening. Or not, and you don't have, it doesn't have to be colonoscopy. Fecal blood testing works. There are other options for what works as well. That's one of the reasons why you don't see a whole lot of information on colon screening, because it's a little bit complicated for a topic. We've got a series on it. If you have interest, you can look it up. If you have interest in us covering it, we can put it on the queue to cover a little bit later. So thanks again, Bart, for sharing that with us. No, the prep is no fun. And if you wake up in the middle of the procedure, that's not the most fun either, unless you really enjoyed the alien experience. But here's your choice. Get colon cancer screening, or run the risk of being one of those 50,000 people per year in the US alone that die because they didn't get screened. What kind of choice is that? To me, I think it's pretty obvious. And again, thank you so much, Bart, for sharing that. Aspen shared this. It's a great way for you folks that have an interest in looking at more content. You can take a look at it right there at that link. Thank you, Aspen. Fort Worth West Side. Is aspirin an anticoagulant, a blood thinner, or both? Blood thinner is a non-specific term. It basically means functionally something that decreases blood's clotting ability. Now, there are two major ways of decreasing blood's clotting ability, a blood thinner. One is to decrease the blood's ability to clot, but a clot forms on a lattice work of platelets. You remember what platelets are? Aspirin is actually an antiplatelet activity. So what it does is it keeps platelets from forming that lattice work that the clot usually develops on. Now, for those of us who have paroxysmal atrial fib, why am I talking about that? Here's the reason. People that have unrecognized atrial fibrillation, and that's most of the people with atrial fibrillation, have risk for stroke. Again, it's like diabetes, prediabetes. Most of us that have it, it has not been diagnosed, yet it creates 5 to 7 times the risk for stroke. This becomes a very important question that Fort Worth West Side just brought up. Aspirin may help a little bit if you look at the data, but not very much. The things that do help are things like Eliquis, rivaroxaban, Xarelto, what we call the new oral anticoagulants. Now, they're different from aspirin in that they don't stop platelets from forming that lattice work. They stop the actual development of the clot. Now, why is that? Why do you think that's different? We don't really know for sure, but most of us in this space think that it's because those of us with atrial fib form a clot inside our heart. It's not so much a clot that formed elsewhere, and it's not a clot that formed from release of soft plaque, which is an internal traumatic event. So that may be the reason why those types of blood thinners, the oral anticoagulants, prevent stroke associated with atrial fib, whereas aspirin doesn't. So a lot of interesting things to talk about. We're not going to be going into the atrial fib component of that unless we get questions next week. We're going to talk about, again, a new meta-analysis that's coming out and saying, we don't think that it's worth it. It's similar to the Esprit trial, and it's similar to what you saw with the change in the preventive medicine guidelines for primary prevention. And then for those of you that are listening and thinking through it are saying, does that mean I need to stop my aspirin? Let me be really clear. For the majority of us baby boomers, that does not mean you need to stop your aspirin. If you have plaque, that's no longer primary prevention. And everybody agrees on that. It's just that the communication's not that clear. So again, we'll talk about that next week. Thank you, ET himself.
Doc,
Yes.
sorry for the interruption. Can you please move forward or lower down your camera because the comment is covering the face. That's great.
Thank you so much, Aspen.
You're welcome.
So Charles Keefe, hi doc, CT scans destroyed my kidneys. So to blood thinner. I stopped, just use baby aspirin every 12 hours. Also angiogram destroyed my kidneys, though placed a stent. Thank you so much, Charles, for sharing that. I mean, it's folks like you, Charles, that have the bravery, the guts, the temerity to share major challenges that you've had in this space that helps people understand this is not just some goofy internet doc prevention guy like me talking about something that's theoretical. This stuff impacts lives. And when folks like you whose life has been impacted share that, it makes a difference. Thank you so much. Gator Bear Geek, thanks for what you're doing for Lower Alabama. I wish I had a place in Dothan so I could send my parents. You know, as we get further stabilized in the Lower Alabama area from our operations perspective, we are looking to go to Central and Northern Alabama. So keep posted on us. Thank you so much. Fort Worth West Side. Since Cardio Risk isn't the only clinic doing a correct CIMT, what questions should one ask if they're investigating other clinics that offer CIMT to see if they're compatible with Todd's group? That's a great question. I have found a group in LA that does a good CIMT. There's a group in Alabama that does, not Alabama, in Atlanta, Georgia, that does a good CIMT. There's a doc in Nashville that does a good CIMT. And so, but there's not a lot. And I wish I could tell you how you could make your own choice for that. Unfortunately, it's a clinical quality control program. Todd, for example, has a doctorate in managing these kind of screening processes, the quality components of it. And you just don't see that a lot with most imaging centers. So you tend to not see good CIMT images from most centers. I still get a whole bunch of people that come to me. I had a lady that came to me yesterday, for example, that got this from the Lifeline van. And I get a lot of folks that bring those. And I've actually talked to and worked with some CT angiogram, some CIMT techs that had done some work with Lifeline. The bottom line is Lifeline pumps people in too quickly and out too quickly to where they just can't do the quality control that you need to be able to do. And unfortunately, that's a time issue with Lifeline. It's a knowledge issue from most of the standing imaging centers. Gator Bear Geek, keto diet after diabetic ketoacidosis. I'm assuming that's what their DKA means. an MI, which means myocardial infarction, that has my type 2 diabetes in remission with all markers except LDL and low creatinine. Great. I'm not sure what else to do for prevention besides more resistance work. Thoughts? Well, this may sound really goofy, but my first thought is some stuff that we used to hear time and time and time again when I was managing healthcare for Toyota. What did I say? Toyota. So here's the punchline, the connection of the dots on that. It's one of the key components of Toyota lean processing is first find the root cause. Now that's the issue. I think there's a lot of root cause work. I mean, you've given us a lot of cause-related information: type 2 diabetes, diabetic ketoacidosis, but we still we haven't assessed the situation completely. If you have interest, again, I would say call Michelle at 859-721-1414. That's 859-721-1414. And thank you, Aspen, for showing that up in the corner. Fasting glucose in the 80s, postprandial under 100, but for some reason, showering will raise glucose from 80s to 120s. Struggling to figure out what could be causing that. You're not the only person, Gator Bear Geek, that has blood sugar go up from showering. That's kind of weird, but that's not the first time I've heard that. It's an interesting perspective, don't you think? And I think most of us would assume, well, it's got to do with some kind of adrenaline component. But again, all right, I'm not going to be able to diagnose you here. Do a full assessment. It takes a long time, typically at least half an hour, maybe an hour, for me to go through these details with the patient to understand what's going on with them, assess their situation, talk about and look at their root causes and the things that we can do to adjust root cause issues. Fort Worth West Side. You've said you typically suggest 5 milligrams of Crestor for inflammation. Cardiovascular inflammation is what we're talking about, by the way. My elderly in-laws take 80 milligrams per day of pravastatin. Obviously a high dosage, but is there a danger of taking, say, 10 to 20 milligrams per day? Well, the answer to that question, Fort Worth, is clearly going to depend on who you talk to. Obviously, if you talk to their doc, I would expect their doctor to say, oh, yeah, that's going to be very dangerous to decrease that amount. That's why, if it weren't, I wouldn't have given them the higher dosage. So you're going to get some debate there. Here's the reason that I usually use the lower doses. People think, and most docs give statins for LDL level, cholesterol level. That's not usually what I give it for. I give statins for cardiovascular inflammation. It's a very different reason. But if you've got plaque, it's really clear that you've been in a cardiovascular inflammation stage. You didn't know it, you didn't feel it, or you would already know that you have plaque before we discovered it. Now, it's a thing, there's a technical term, I'm going to use it, pleiotropic. There's a pleiotropic mechanism. Again, sounds technical, but if you have done any third grade astronomy or maybe 12th grade astronomy, you might have heard the term, the Pleiades. You remember the Pleiades? What was that? The Seven Sisters? So pleo is the root for that word, and it just means many. And here's the bottom line. There's more than one mechanism for statins. Most docs and patients think about lowering LDL. That's not what I usually use it for when I use it. I usually use it for decreasing cardiovascular inflammation. It does a good job of that. Some statins do, some statins don't. For example, the most popular statin, Lipitor, does not do as good a job on cardiovascular inflammation. It does a great job of lowering LDL, but it doesn't do as good a job on cardiovascular inflammation, especially if you're female. Well, that's half the population. Or if you have prediabetes, well, again, prediabetes is more like 80% of the population. So I don't use Lipitor. I've used it maybe 1 or 2 patients total over the past decade. There are specific statins that tend to do better. Rosuvastatin, Livalo, pitavastatin, some of those. And again, for this purpose, for lowering cardiovascular inflammation, those lower doses are very helpful, and that's almost always all you need. And think about it. For those people that are having symptoms associated with their statins, guess what these lower doses do to that? Greatly decrease it. So thanks. It was a great question, Fort Worth. I appreciate it. Rahul Sharma. Hi, Doc. What is the radiation exposure to a patient in CT coronary angiogram, 128 and 256 slice of scans? Oh, as I said, the answer to that, that's not a technical, I tend to be more concept in terms of my own brain. I did get into the details on exact radiation exposure for CT, for calcium score, for CT angiogram. And one of the things for most people, here's the thing, Rahul, it's a great point. I will go into some of the concepts. And again, if you really want the details, and it sounds like you do, the details are in the book. Now, I'm not trying to, well, the details are in the book. But here's a concept that you can remember about radiation and cardiovascular screening. Calcium score is real. It used to be in some places significant, but it's not significant for your typical baby boomer who's worried about, do I have a 10 or even 5% possibility of having a heart attack, an event over the next 10 years. The radiation exposure from a calcium score, it's there. It uses CT technology, but it's like 1 in 1,000, even if you did it all the way back at birth. So that's just no comparison. A lot of my folks that listen to me listen to Ivor Cummins as well, and his channel is really focused on calcium score. He makes the point that radiation is insignificant for that group. Yes, it is. And I don't think radiation is a reason to not get a calcium score. But that's not what you ask. I think you're asking about radiation for CT angiogram. It's more, but again, if you're at the point where you have risk known already, if you've had a stent, well, stent maybe not a good example. If you have known risk already, you've got some plaque, you've got some significant family history, you're over age 50, we start finding you've got some undiagnosed prediabetes. Once you start getting in those areas, the radiation associated with CT angiogram is not significant. In fact, when you look over, well, let me give you 2 other points about radiation. So there's 0 radiation from CIMT. It's ultrasound, and ultrasound is non-ionizing. It doesn't cause any health impact. Any kind of X-ray does. Now, where do you get into real problems with radiation? You get into real problems with radiation where you have these docs, where you have a young person, like in his 40s, who's had some symptoms. The doc brings them in, says, you know what, let's do a thallium stress test, which has radiation. And let's do a, you know what, maybe we need to do even an annual cardiac cath. Well, thallium stress tests and cardiac caths, big radiation. And those are, again, things that get way overused. And it's not just because of the major risk that those things bring to the table is not from their radiation. The major risk they bring from the table is going down that slippery slope of saying, oh, we see something, therefore let's stent it. Stents and bypasses don't prevent heart attacks. So it was a great question, Rahul. Thank you so much for bringing it up. It gave me that opportunity to go down that bunny hole. Johnny, hi, Doc. Was Arnold's fainting definitely due to plaque, or might it have been due to electrolytes or whatever? Great question, Johnny. If it had, I didn't recommend the statins at the end of the day because of his fainting spells. And nobody ever knew the answer to your question. But what happened was he was 63. He had that. People, you go in, your doctor's automatically going to start thinking of that. He had multiple fainting spells when he went into that ER. So it could have been. And at the end of the day, it also could have been that he did have some soft plaque and he was throwing some small clots. That happens. And he did, and that was resulting in what we used to call a TIA, transient ischemic attack. A TIA, or transient ischemic attack, is a small non-permanent stroke. It may have been that. We don't know. It could have been something very, very different, like exactly what you just brought up. Thanks. Great question. Appreciate you pointing that out. Tired looking for name. Thank you so much, Tired, for the contribution. For those of you who don't know, there's so again, if you enjoy this content, if you think it's valuable, here's the thing. Myself, some of the docs I work with, we make this available. The vast majority of the content is available for free right here on the YouTube channel. The goal is to help people be aware of the pros and cons and how to prevent just heart attack and stroke. And you know what? Just heart attack and stroke are the number one cause of death and the number one cause of permanent disability. And oh yeah, it helps us prevent Alzheimer's. So again, lots of huge, important pieces of information. We're a bunch of busy docs. We all have stuff going on in other places, like I mentioned in the Alabama project. But we're getting a lot of appreciation. We've got over 100,000 views, subscribers now. And recently, you may not know this, a quick ad for our content. We also do, oh gosh, I'm blanking on the name, podcasts. And it's the same content. We make it available on podcasts. Sam in our production team thought of this project a few months ago. Aspen and Gilbert worked with him on taking the content from our videos and making it available in a podcast format. Recently, our number 5 country in the world in terms of uptake on this was China. So, I don't want to get into political debate about China, but there's a lot of uptake of this information. Contributions like that, Tired looking for name, make a big difference in terms of helping us get that information out there. Another great way to make a big impact. And if you want to do it the way Tired did, you can go to Super Chat, and Aspen's showing you how to do that. We also have Patreon. If you go to the Patreon account, and maybe, Aspen makes a good point. We should probably have a little, I forgot. You're way ahead of me. If you'd like to do Patreon, it's right there. PayPal, live Super Chats. So great. Thanks, Tired, for giving me that opportunity to plug our stuff. It makes a big difference. People all over the world are getting this information and using it to prevent heart attack, stroke, disability, and ugly death. Maximize their life. Rahul, another comment. Hi, Doc. What can those with allergies to blood thinners do to get their benefits? Well, again, that starts to take me down. First, assess the situation. Allergies to which blood thinners? Every one of them? That starts raising red flags for me. What kind of allergies are we talking about? And there you go. So, Rahul, to your point, again, we have to understand what's going on. We have to assess the situation. We have to understand the root cause problem before we can come up with a recommendation. Next Level Sports Medicine. Thank you and happy holidays. Next Level. That sounds familiar. Living the Dream, JFP. Are you accepting new patients? Well, we are. We're not going to be accepting many more new patients. There are a few slots available. If you have an interest, I think Aspen can show you the phone number. Call Michelle at 859-721-1414. That's 859-721-1414. Reminder, Ravender Reddy. Hi, Doc. I'm Ravender. Is vitamin D3 and K2 enough to remove plaque? No. For how many days should we intake these vitamin-based supplements? Usually when people do start taking them, they take them forever. Now, those are quick, easy comments. Vitamin D3 is a long, long story. Most folks do not have, especially boomers, do not have enough vitamin D3. There's been a lot of changes on the requirements and the recommended levels for vitamin D3. The standards used to be 15 to 30. You want somewhere in that area. Well, that was back in the day, 20 years ago and further, when we used to think vitamin D3 was mostly just there for preventing rickets and having strong bones and teeth. And then, you fast forward to just over the past 2 years, it's become really clear that people with low vitamin D3 levels actually were much more likely to have cytokine storm and die from COVID. So D3 is a big deal. Thank you so much, Ravender, for bringing it up. Now, here's the reason that Ravender mentioned K2. When you look at our content, K2 is a very popular topic, a lot of interest in K2. And here's why. There's this sort of urban myth out there that K2 pulls calcium out of the arteries. In other words, so the next logical thought is, well, it must remove plaque from my arteries. And that's not the way it works. It's a lot more complicated than that. If you have interest, I've got maybe a dozen videos now on D3, maybe a dozen videos now on K2. There is evidence that K2 actually may have some of that impact, but it appears that it's probably more associated with K2 having an impact on prediabetes. So again, really good question, but these topics get significantly more complicated. Not something I'm going to be able to answer in a 2-minute response on a YouTube Live, but we've got that content out there. Fort Worth West Side. Saw your interview with Dr. Craig Brown on eye issues. That was a while back. And, it's interesting. Dr. Brown just sent me an email this morning with 5 new papers showing the positive impact of AREDS related stuff, a thing he calls ocufolin. That's a vitamin way of retaining good eyesight. Most blindness is due to, hold that thought. Most blindness is due to what? Diabetes. And guess what? AREDS, the vitamins associated with that you give for eyes, have been proven to prevent most diabetes-related blindness. That is, most blindness. Now, how many docs know that there's a vitamin group that prevents blindness? if you have an interest, just go to Google, or interestingly enough, just go to Amazon. You'll see tons and tons of providers out there providing AREDS related vitamins. So Fort Worth, you gave me an opportunity to go down that bunny hole. Let me go back and finish your question and see if there's anything I can respond to or help. Based on the video with Dr. Craig Brown, who's an ophthalmologist with a public health and prevention focus, who did appear on the channel with me. Based on that and other issues you've covered, it seems insulin is a hidden culprit in just about every major health issue. So let me repeat that. I was having some problems with it. Based on the interview with Dr. Craig Brown and the other issues you've covered, it seems insulin is a hidden culprit in about every other health issue. No, only the most important ones, like diabetes, like kidney disease, kidney failure, like blindness, like heart attack, like stroke. Oh, did we mention Alzheimer's? So thank you so much, Fort Worth. Great point. Excellent point. Yes, insulin is a big deal. And here's the problem, or here's why it's not just insulin alone. Although insulin alone is an issue, there's plenty of evidence that's indicated that cardiovascular inflammation is created by insulin, even if your blood sugars are normal. So yes, it's a big, big issue. Thank you so much for bringing it up, Fort Worth. Wonder if insulin causes diminished vision loss and glasses in addition to aging. Well, yes, this is a glucose metabolism issue, and therefore the majority of it is, and therefore it's an insulin issue. Bambi Grage, good to hear from you, Bambi. Long time no talk to, or long time no see. Okay, I'm calling today to get my first colonoscopy, 50 years old. Bambi, thank you so much. Bambi actually inspired us for one of our more popular topics. And we mentioned you on that video, Bambi. This was what, 3 years ago. I can't remember what it was, but I do remember the name. Thank you so much for your comment. And you know what? We might have saved a life right there. Chuck K. Hi, Doc. Have you talked about your involvement with Jubilee Health? Yes, I have. I'm trying to find a primary care doctor that understands cardiovascular health and doesn't repeat the current federal guidelines. Are you in Lower Alabama? Because that's where we're located right now, Baldwin County. Many people might know that place. You might remember it more as Gulf Shores, the Gulf Shores area of Alabama. It's a big, big retirement space. It's growing. Baldwin County, where it's located, is one of the biggest counties in the country, clearly east of the Mississippi, one of the biggest. And it is a wonderful area. And they're just retirees coming in there by the dozens, by the hundreds, by the, I think, thousands each year. So major growth area for baby boomers that need good prevention. So yes, we focus on that kind of prevention in that program. And I hope that helps, Chuck. Thank you so much for allowing me to give a little explanation of the Jubilee Primary Care program. As you see, Aspen is holding up a little image right here, which shows you how to find Jubilee Health and how to get information on it if you want more. You can call 251-444-1999 and or visit www.jubilee.health. Now, while we're talking about Jubilee, I gotta ask two questions. On the trivia side, anybody recognize that little image? It turns out that that's an old-fashioned lighthouse that's right out there in Mobile Bay. So if you lived there, you probably know that because it's a very characteristic image. The other question is, do you know where the term Jubilee comes from? Jubilee is the term for something really interesting, really weird that happens every few years, sometimes more than once in that year. But seafood starts just bubbling out of the Mobile Bay. If you think that's crazy, look it up on YouTube. You'll find some very interesting videos about it. Jubilee, Mobile Bay. And here's what's happening. There's a geology kind of thing where there's a lot of, I think it's carbon dioxide, something that's not oxygen in the bed, the floor of the Mobile Bay. That's just the way the geology's set up. Well, when that stuff bubbles up, the living creatures that need oxygen in the water get way low on oxygen, and they'll again start bubbling out of the water, jumping out of the water. And so the term for that with local lower Alabama citizens is, hey, there's Jubilee. And so what they'll do is there'll be like a call cascade. Jubilee's happening. You run out with a net and start grabbing up all the fish and crabs and you name it during the Jubilee. So that's what Jubilee is. Thank you again, Chuck, for giving me that opportunity. Gator Bear Geek, after begrudgingly accepting Crestor due to high LDL particles, LDL cholesterol, and low particle size, it seemed to help with discomfort from gallbladder sludge. Does that make any sense? Believe it or not, you can connect some dots there. When you think about what's the major component of gallbladder sludge, gall, what's the major component of gall or bile, the bile, it's cholesterol. Really? Yeah, that's it. The major component of bile, which your gallbladder stores and which can solidify and form into stones, and which the gallbladder in your body uses to digest fats. You release it out there, and it dissolves fats that you've eaten. Well, now, how does that happen? Well, think about it. Again, so many things would be just absolutely obvious if you think through some of the basic stuff. Fat doesn't dissolve well in water. Fat dissolves well in oil and fats. So that's why a fatty meal stimulates the release of bile. Bile helps you digest fats. And bile, as we just said, is made up mostly by fats like cholesterol. So there you go. For those of you who are technical term purists, we could say, look, cholesterol is not a fat. Cholesterol is actually what the scientists, the docs, call a lipid. But fats are a lipid, cholesterol is a lipid, oils are a lipid. Great question, Gator Bear Geek, and it's very interesting, and I bet that's what's going on. Bart Robinson, thanks for the colonoscopy story. Hopefully I'll be knocked out really good. Yeah, warning. Sure as heck don't want to wake up. Yeah. A lot of people really don't have that kind of pain. Nathan was surprised when that happened with me, but not completely. He said, people have discomfort, but not alien popping out of your stomach kind of stuff. So I guess I was just lucky. Bart Robinson, good luck, Bambi. I agree. James Cantor, good to hear from you, James. Less people, maybe after Thanksgiving. Yeah, I agree. Maybe a Thanksgiving issue may also be people, it's just like most of the folks on this channel have heard of calcium score and CIMT, but even most of the folks, a lot of folks, even channel veterans for this channel may not have heard of CT angiogram. It's newer than any of those. And you got to, it's just not that well known. And doctors certainly aren't talking about it. if you want to get financial, yeah, it doesn't make the doc as much money as the other stuff, the stuff that keeps getting done over and over again, like a stress test and a cardiac cath. But that's, although that's real, that's not all the reason. There are other reasons as well. One of them just has to do with how quickly information permeates the medical community. And unfortunately, quick is the wrong word. It's like opposite day. It's very slow for key information to get out there. John Tucho, I've really enjoyed today's presentation on the CTA. I have had the echo last year, but was wondering how many years should I wait to have a CTA? Thank you. If you haven't had a CTA and if there's reason to suspect problems, again, I would consider two things. Number one, the CIMT, three things: CIMT, calcium score, and now CTA. And to get deeper, so here's the other thing. The vast majority of what I'm recommending on a regular basis is the CIMT. And again, the problems with that. About 90% of what I end up doing in terms of imaging is CIMT. And it's because even in the suboptimal CIMT, you still can often get the most important information, and that is there soft plaque? Now, I won't get into detail on how many, off the street CIMTs, lifeline CIMT, and most of the off the street CIMTs don't really get soft plaque either. But again, not going to go down that bunny hole. Maybe I should just leave it at that. It's a good question. Those are the three things I would consider. There are other ways, like we said, real quick, reiteration of the summary. There's a whole plaque is incredibly important, but we don't have great ways of measuring it. Framingham is the first way, and that's not a measurement. It's just a guess made by your doctor when you walk in and he's looking at and he or she's looking at and thinking about your risk factors, your age, whether or not you've smoked, if you have, how many years, what your LDL might be, what they may or may not know about your insulin resistance, which they usually don't know, et cetera, et cetera, et cetera. And then they come up with some guesses. The vast majority of docs really don't go that detail. They just look at you and say, okay, how old are they? Have they smoked? Male or female? And what's their LDL level? And they come up with a guess based on that. And they call that the Framingham. We can go deeper. I think we've talked about the Framingham. If you have a question about Framingham, it's a major research program that was done in a town about an hour outside of Boston. It's got more information about the development of cardiovascular disease in a research format, research databases, than any other area in the world in terms of science. And more science has come out of that in terms of risk evaluation and prevention. So you got Framingham. Then you've got the next couple of standards. Stress tests. Hey, doc, can we do a stress test? Well, 2/3 of the people don't have enough plaque to block their blood flow in their arteries. That's 50%. 2/3 of the people that have plaque don't have 50% occlusion. Those are the people that are real risk for turning into the next Tim Russert, have a negative stress test and then die a few weeks later from a heart attack. The next one, as I mentioned before, is cardiac cath. Very expensive, very painful. Do you really want to go there? And even more, the biggest issue is once you start getting that stress test, that cardiac cath, and that cardiologist that did it says, I think I need to do a stent. How are you going to say no? In most cases, they have you sign off for the stent before they even go in there. So slippery slope, be very afraid if you start talking about getting those done. Before you get those done, there are certain situations, I think, I must assume, where you might not want to get one of these beforehand, but I can't imagine when it would be. On a standard basis, I find myself telling people time and time and time again, before you start getting a stress test or a cardiac cath, think of a CIMT. If you can't get a good one, think of a calcium score. Those are available, easy, cheap, well standardized, get them anywhere. And now start thinking about a CT angiogram. So again, thanks for bringing up the point. I hope that helped. James Cantor, I had my CIMT at Rex Heart and Vascular Hospital. They said both sides were none to minimal. Are they supposed to give me a number? Yes, they're supposed to give you numbers. They're supposed to give you delineation of how much plaque do you have. If of the plaque that you have, is it soft, calcified, or heterogeneous in between the two? They need to give you that information. If you do have specific plaques, in other words, more than 1.3 millimeters, where are they located and how many did they pick up out of a quick sampling? They should also give you information regarding arterial age, estimates of, okay, your arteries, you're 62, but your arteries are those of a 70-year-old or 80-year-old. They should be giving you all of that kind of information, and they usually don't. Thanks. Great question. John Tocho, already take 5 milligrams of rosuvastatin. Very good, John. Thank you so much for sharing with folks. I talk to more and more people that have pulled that information off of the channel. We talk about it a lot, and are already doing it by the time they see me or by the time they make a comment on the channel. Thanks again. Ravender Reddy, hi doc, what are the alternatives for statins, and suggest me an alternative? In terms of drugs that actually decrease cardiovascular inflammation, the ACE inhibitors actually, ACE inhibitors are usually given for like ramipril, lisinopril. Those are usually given to decrease blood pressure, but they also decrease cardiovascular inflammation. In fact, we will often look for just minimal, at least, high blood pressure in patients that have cardiovascular inflammation as an excuse to say, look, you know what? We know that the ACE inhibitors actually help in this space. And guess what else? For those that have a problem, that have plaque, the impact on cardiovascular inflammation from low-dose statins and ACE inhibitors is not additive, it's multiplicative. Think about that. Gator Bear Geek, can you share the name of the CIMT group you mentioned that's in Atlanta? Oh, gosh, I can't, but Michelle can. She knows the group. We've had a couple of folks go there. Call her at 859-721-1414. Bart Robinson, really enjoying your book. See there? Believe it or not, I keep saying it's dull like an encyclopedia, but thanks again, Bart. A lot of folks keep saying you're not giving your book enough credit. He's enjoying it. New nurse practitioner went to Frontier Nursing. Oh, you know what? Right here in Kentucky, that is like 5 miles from my house, maybe not even that far. She's making an effort to start her own functional practice. I'm intrigued by that. I am too. She wouldn't be the first nurse practitioner I've met that's done that. Tell her if she'd like to get in touch, maybe I can help. RJMJ, $20 super chat button. Thank you so much, RJMJ. As I said, we've got, as you hear, Aspen makes a major contribution to this channel. The rest, there's actually not one, but 2 teams of folks. One team is in the Philippines, another is in Mexico. We've got docs, good prevention docs in Mexico, Jesus, that help us with content. As you can see, Aspen and Gilbert both do a great job in terms of co-hosting this, because I'm not the technical guy, is obvious. And this kind of information, this kind of contribution, this kind of information's not easy. It takes resources. I'm comfortable providing as much as I can for free, but we need some financial help to compensate, to pay salaries for folks like Aspen, Gilbert, Sam, who's on the team that does some of the technical pieces, Dr. Jesus, Carolina, Ceci, and of course, Michelle. Michelle helps us run the channel as well. Bart Robinson here in rural South Jersey, that is. There you go. Thank you so much for clarifying. I thought it was Jersey. B. Flint, great info. I'm a new patient. Have had bad reaction to Lipitor and even only 5 milligrams of Crestor. Would you suggest bergamot to lower A1C and glucose? Bergamot and, oh gosh, I'm having a senior moment. What's the other thing that we talk about all the time with bergamot? There are a couple of supplements that help with glucose metabolism. Some of the more obvious and popular and well-known would be, for example, like cinnamon even. There is some, it doesn't have a huge impact, but it does help. There's clearly evidence that it does help. Vitamin D3. Now, we talk about that for a whole bunch of other things. Why would I bring that up in terms of glucose? Well, there's significant evidence. Now, you can debate it, but clearly significant evidence over whether D3 actually contributes to prevention of prediabetes and diabetes. So there's a lot of information. If you'd like to join us for one of our supplements webinar, we do have a webinar where we go into multiple supplements and people get a chance to just have some conversation regarding those. As usual, Aspen's on it. He heard what we're talking about and he's sharing that right there. You can go to that link if you'd like to find out about the supplement webinars. Thanks, Aspen. Let me see. We're okay. RJMJ. Thank you so much, RJMJ. Can't wait to work with you personally. I must have done something really good in a previous life. Oh, wait a minute. Thank you. As you see, RJMJ has given us a super chat. And again, thanks so much. Can't wait to work with you personally. Must have done something really good in a previous life to have been able to connect with you. Thank you. Thank you so much, RJMJ. I appreciate that recognition, those kind words, and the interest and the contribution. Appreciate it. Bart, well, look, you know what? I think maybe we've gotten back into a loop here. Let's make sure that, yeah, we've gotten into a loop. Hold on just a second. Just wanted to thank you for your team for being so, thank you, Rahul. 32, get dizziness, head inflammation, cold legs on taking drugs, aspirin, clopidogrel. So the doctor said I might be allergic to the whole class of blood thinners. I wouldn't assume that at all, Rahul. I would, not just from what you've said. That's a much longer conversation, but I don't think the information, that's not the reaction I would have when I hear just what you put there. Chuck K, great interview with Dave Feldman. I find an engineering view on health very interesting. Dave, thank you so much. I do also. Very interesting. Bart, yep, good discussion with Feldman. Ada Reeves, good morning, Doc. Good morning. You must be somewhere maybe in the western half of the continental U.S. or someplace like that. What's your opinion on ezetimibe for lipid management? There's a place for it, just like everything else. It's got its pros and its cons. You start adding ezetimibe and you've got some increased risk in terms of some, rhabdo and some of the other things. But there's clearly a place for ezetimibe. PT Health. My doc said with 1300 calcium score, a CTA would not work out too much. Too much calcium blocking to see if much use. Is that true? That is not so clear at this point. Yes, you've got a significant calcium score. I've got plenty of people, by the way, who are very stable and now very comfortable with much, much higher calcium scores than that. On several of them, we've gotten really good information on a CT angiogram. He wants a nuclear stress test. Oh, and like I said, be careful about getting a stress test and especially a nuclear stress test. I mean, there are places and times to get stress tests, but it's like 10% or less of those that are actually done. John Tocho, I agree with Bart. Really enjoyed the book. Thank you so much, John. I appreciate that. ET himself, the Oxford slang diction. I don't understand that, ET. Why you? Super chat again, another super chat. Thank you so much, John. I appreciate it. And again, this kind of stuff makes a difference. Another thing that makes a big difference is to post this content on your Facebook page, your Twitter, things like that. Because here's what happens. When somebody clicks on that and it brings them from another social media into Facebook, the Facebook algorithm reads that. They recognize that and they say, this was important enough information for one human to refer another human to come back and take somebody from another social media channel back to YouTube. You know, the algorithms are out there competing with each other like mad. You help that's a great free way, absolutely free, doesn't cost you anything, to help boost this information, getting it out to people that need it. And as you can tell, there's not a lot of people in this world that don't need this information. Thank you again, John. I appreciate it. B. Flint would like to hear your information. That's what we do all day, every day, B. Flint. Chuck K, thumbs up. Yes, thumbs up is another way to just click the thumbs up, and the algorithm reads that. Thanks, Chuck. Ritesh Davda is EECP. Ritesh, maybe if you could spell that out. Mezzanine, good to hear from you, Mezzanine. Haven't seen you for a while. Switched off of ezetimibe and started 5 milligrams rosuvastatin 3 times per week. Concerned more with anti-inflammatory benefits over strict LDL control, really. Yep, great point. And, you know, somebody else brought up ezetimibe. I really didn't go there. I use very little ezetimibe. And this is the major reason, Mezzanine. Thank you so much for bringing it up. Ezetimibe, the fibrates really don't have an impact, any kind of documented impact on cardiovascular inflammation. The low-dose statins do. So that's one of the biggest differences. Even with a previous history of statin intolerance. Thank you for sharing that as well. You know, if you've got statin intolerance, there's unlimited evidence and information that you need to look a little bit deeper. How big a dose was it? How did you define statin intolerance? Are there other options if you actually need it? Mezzanine, great job of deciding to push through the hesitancy on that. Since the inflammatory information came out, pardon the pun, or there's a lot of information coming out about all the bad stuff with statins. That happened, with British Medical Journal, British Medical Journal and Lancet. They started getting into a feud over this. This was over a decade ago. People really became very focused on statins. And yes, statin intolerance does happen. But when you look at the majority, way over half of statin intolerance is fairly easily, if the patient's interested in going there and willing, pretty easy to overcome. Changing dosages, changing types of statins, just a bunch of different things. And the reality, Mezzanine did it right. And thank you so much for suggesting it, Mezzanine. There are so many people that have missed out on some significant benefit because of this statin fear or statin intolerance. It's real, but there's so much that can be done that people just don't do because of fear or frustration. I've been a statin hater myself. I didn't take statins for about a 3-year period when I coulda, woulda, shoulda, probably have taken it. I understand that. Thanks again. So, B. Flint, I read your book too. Oh, thank you, B. Flint. I appreciate it. Fort Worth West Side. See you next Wednesday. Thank you so much. And guys, thank you so much for your interest today. And we'll see you next week. Meanwhile, Aspen and the team will be chopping up more interesting, smaller format parts of the content to make it available during the rest of the week. Thank you again.